Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present No Thrombosis Live Inbox, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our course director, Dr. Hiremat sir. Sir is director at Cath Lab, Ruby Hall, Pune. Sir is president CSI 2017, program chair CSI Conference 2016, convener National Interventional Council of India CSI 2004 to 2006. Sir has proctored many interventional cardiologists and has given live courses across the globe. Sir has great experience in peripheral angioplasty, including legs, iliac, and carotids. Sir has also participated in some groundbreaking clinical trials. Thank you, sir, for your continued commitment and guidance to us for running this program regularly. Your expertise and fan following has made this program a resounding success. Our distinguished moderators, Dr. C.B. Keshavamurthy sir and Professor Rajiv Gupta sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. It is an honor for me to introduce our distinguished moderators for today. We have Dr. C.B. Keshavamurthy sir. Sir is Chief Consultant Interventional Cardiologist and HOD at Manipal Hospital, Mysore. He is past president of CSI Mysore chapter. He has done pioneering work in primary angioplasty at Mysore, established interventional cardiology centers at Salem, Erode, Tamil Nadu, and performed several first ever procedures in that region between 2000 to 2004. Sir has several national and few international publications and presentations to his credit. He has teaching experience as DNB teacher at Vikram Hospital, Mysore. He is principal investigator of Rocket AF, Reduce It, Credence, Horizon Trial, 33 other national clinical trials, and registry participation as primary and co-investigator. Sir is also presenting a case today, and the topic for his case is use of drug-eluting balloons in complex coronary stenosis. It is an honor for me to introduce the second moderator for today, Professor Dr. Rajiv Gupta sir. Sir is professor and head at Department of Cardiology, Cardiac Science Center at Gandhi Medical College and cardiologist at Associated Hamidia Hospital, Bhopal. Sir has over 38 years of illustrious medical service to the ailing humanity, faculty to various international and national societies, associations, councils, and universities. Sir is examiner to MBBS, MD, and DM cardiology. He has brilliant academic record embellished with innumerable orations, fellowships, medals, awards, and prizes. Recently, he received Excellence Award in Clinical Cardiology by Indian Society of Cardiology in 2023. Sir has served as Chairman Scientific Committee of Indian Medical Association MP State Conference in 2016. Sir has served as President Indian Medical Association Greater Bhopal Branch. He has published 106 research publications in various international and national journals. He is co-investigator for CREATE study, ICMR study of heart failure, and investigator of ICMR study on CVD management. He is author of many books and books chapters in cardiology. Thank you, sir, for joining. I would also like to introduce and extend a warm welcome to our esteemed speaker for today, Dr. Pranav Shamraj, sir. Sir is consultant cardiologist and director at Cath Lab at BKL Valavalkar Medical College and Hospital at Chiplun, Ratnagiri, Maharashtra. Sir is presenting a case today on complex angioplasty CTO in ACS. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us today. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our course director, Dr. Hiremat sir. The meeting will proceed further with the case presentation by Dr. Pranav Shamraj sir. Following this, we'll have a discussion on the case where all the faculty members will participate. Second case will be presented by Dr. C.B. Keshavamurthy sir. It will be followed by discussion among the faculty members. Post the discussion of second case, we'll have the concluding remarks by our esteemed course director. I request audience to post their questions in the comment box so that we can take up those questions in the end. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. I request Dr. M.S. Hiramat sir to share his opening remarks for today's topic. Over to you, sir.
Dr. Rishikesh, thank you for that introduction, and good evening, everybody. The Emcure has taken great pains in getting all of us together. We started as a very small focal meeting, and I believe the audience attendance today is exceeding 800 or 900 sometimes. So it's indeed getting to be a very popular forum, and many young interventionists like to present their cases. All of you who are listening today, I think, must make a very positive effort that their case will be shown here, and accordingly get in touch with Dr. Shikesh so that we can have your presentation sometime. So let's start with your case, Dr. Pranav. You're practicing in Chiprun?
Chiprun, yes, sir. Good evening, sir.
Yes. So I like that city. I was at Pofri, which is a power generation center for Koina, and my father was actually in Koina projects, so I know that area very well. I'm glad for today.
Thank you, sir. A very good evening to all respected teachers. Today I am presenting a case of STEMI, acute coronary syndrome, who presented, I mean, the patient was referred, and after the angiogram, we thought it as a simple case, but it turned out to be something different. So this was a 55-year male, hypertensive, non-diabetic. He presented as acute coronary syndrome. So this was the ECG when the patient came to us. Patient was referred on day 4th after stabilization. So thought it as a the changes were mainly in the lead 1 and AVL, and also in V1, V2, and V1, V2, with some changes in lead V3. So more of changes in the lateral wall with as the evolved STEMI pattern. And patient had a good LV function.
Dr. Pranav, if I could ask you, looking at the ECG, what crosses your mind? Which vessel is involved? I think before we take any patient to the cath lab,
yes, sir. Yes.
We should all have a little discussion. And
yes, sir. Yes. Actually, with this ECG, I see changes mainly in whenever I think of AVL, I always feel the diagonal or area which supplies the lateral wall mainly involved.
Any comments from you, Dr. Keshwa?
Yeah, there are definitely anterior wall changes, even in V2, and LED is the culprit. And like the presenter said, it could be a large diagonal branch with the changes in 1 and AVL.
All right, let's proceed.
Yes. So patient had hypokinesia in the LAG territories in the anterior wall and the anterior septum, but it had a good LV function. And he was a tobacco chewer and non-diabetic patient. So this patient is, I mean, they done the case in October. Today I had called the patient, so he's doing good. So this was the RCA shoot, which is showing mild disease in the right coronary artery in the proximal and the mid RCA. Anomalous origin of the right coronary artery with little higher takeoff. And from the RCA, the LED is seen by grade 3 collaterals. And the left system, I mean, I've taken the left system first, but just here slides, I have put it other way. So LMCA looks normal, and LCX continues as major OM. And this is the epicranial view where LED is having and I'll share LED is having a lesion in the mid segment, and after the septal and two diagonal, one upper diagonal smaller size and the major diagonal, the LED is 100% cut off. So from sorry, from the left side, the LED seemed to be filling right up to where it was cut off, and it had a good collateral flow. And this patient was pain-free with good LV function. He presented with biomarker positive and STEMI. So this seemed to be a pretty simple lesion. I mean, in one way that at least there is a good collateral and the ocular segment looks short. Now these are the different views, ariocaudal and the epicaudal view. And this was the still image. So we can see here before the septal, there is an eccentric lesion, which is critical. It could be a, I mean, vulnerable kind of lesion. And then there is a diagonal, which is again disease. And LED is cut off after the septal. And after a short segment, we cannot see it distally. So with this in mind, I took this case to the cath lab for doing the angioplasty. And this was the report, what we had made, the diagram. So started the case with a EBU guide and initially took a regular Workhorse wire. We are using Sion blue or run through and just thought of can we cross the lesion. So after
Do you take a contralateral?
actually, sir, first, I mean, I took a contralateral later on. First, I thought of just poking with the wire if it is a easy channel, the wire goes. And
Yeah, for acute, I think we go with single.
yes, single approach. I thought it's acute STEMI, and this is straight away.
Crossing should not be difficult.
Yes. So, but here actually I'm not able to show because the fluoro was not saved, but the wire was not able to cross beyond this point, and the regular wire was able to enter this channel. So I thought of taking a good support and crossing this lesion. So I took in a micro catheter, and then with the micro catheter support, I thought of again entering the course of the vessel. But unfortunately, because of a septal and in addition to a diagonal there, uh, could not enter the artery. So either the wire was going in the septal or it was going in the diagonal. And if we can see on the right side, sir, as I mentioned, there was a critical lesion just above that septal. And again, it was difficult to navigate the wire. So I took a next wire. Normally, I use the Fielder XT or Pilot 150. So here I tried with the Pilot 150 wire, but I found that with great difficulty I could cross the segment, or it could enter that lesion, but it was all, there were a lot of multiple septal branches, and then the wire kept on going into the small septal branches, and it was unable to enter the distal this thing. So here I took a contralateral injection. So here I thought that this is not something what we are encountering daily. And so I kept the microcatheter there. I took another access and took a contralateral injection to see. I kept the microcatheter and took a contralateral shoot to see till what point the LED is filling. So there is a very short segment, and over that, the LED looks pretty normal and healthy.
Right
So
injection is looking so useful here.
yes, sir.
You can see the LED all the way to the site of total occlusion, and I'm sure it helps you to decide which way the wire should progress.
Yes. So after this, like again tried the same thing with the retrograde shoot to cross the channel, but as I'm showing that it was not able to enter that distal cap. So and again with
The same,
manuals,
you're still using the pilot wire, right?
yes, sir. I was using the Pilot. Then I didn't upgrade to Fielder XT because I thought that is a workhorse wire which I am very much comfortable to use. But then here it was going in the diagonal septal while trying to take it back, or either it was not able to enter the cap. So what I did is I took out the wire. I gave a shape to the wire because it was going in the septals, the small septal branches. So I give a shape of around the excluding the distal 1 centimeter, I gave a shape of 60 to 70 degrees, so that I can at least torque the wire in a desired direction, where at the distal gap I wanted to enter the LED, which was little on the lateral side. So after that, I was able to enter into the LED, and here I can see the wire is easily going down. If I did not,
I'm sure the contralateral injections
yes,
helped you
yes,
to
yes, sir.
stay on course in LED.
Yes, sir. The contralateral, mainly the contralateral shoots were taken, but they were only very few antigrade injections I took, which I'm showing here. And because of that contralateral shoot, and after changing the little shape of that wire, I could enter into the distal LED. So with this, I thought the main job is over, and because this is a STEMI, I will get away with the regular steps of our angioplasty. So here I took a 1.5 balloon and dilated across the mid LED. And after dilating, I saw that there is a dissection above the septal, and it was in my mind that this could be a lipid-rich plaque, or it could be the typical plaque which is called the STEMI, in addition to the occlusion which is below. So I again, to protect the side branch, I put another wire, and I also exchange this wire with the regular run-through wire. So after that, did serial dilatations with a 2O balloon, and then I took a 3 into 32 millimeter sirolimus eluting stent. I have actually taken another AP view, but it's not here. And after this, I deployed the stent. But as soon as after deploying the stent, the flow in the diagonal is lost.
Do you give intracoronary tirofiban or
Yes,
eptifibatide?
sir. I gave intracoronary tirofiban, nicorandil, and even adrenaline. We are using regularly intracoronary adrenaline. But because there was if we see this lesion, this was a like above. It was pretty lot of dissection. Could be lot of thrombus, and maybe there was a huge plaque shift and also shift of the debris. So the diagonal got occluded. The patient was stable. So what I did is I took another wire and then crossed through the strut and entered the diagonal. So after I crossed, I removed the first wire and then just took a 2O balloon, and first I opened the diagonal, and then with one 3O balloon in the LED and a 2O balloon in the diagonal. First opened the diagonal, then the LED, and did a simultaneous kissing dilatation. And this was the final shoot. So to here I concluded that there was I did the pore dilatation in the distal LED stent, and then the diagonal was flowing well. The LED flow was good, and I like stopped the procedures.
The proximal diagonal also is now flowing.
Yes, sir. The proximal actually, sir. I mean, there were this procedure went on little longer time, and there were a lot of shoot. So I did not want to give heavy contrast, and this like almost 120 ml contrast was given, though the patient had good LV function. So little streaming of the contrast during the shoot is seen. So
You didn't aspirate the thrombus with any aspiration catheter.
no, sir, I did not aspirate the thrombus because already it was day 3, and
And you also did not give any tirofiban or
yes,
GP.
sir. I gave tirofiban. I gave. I normally use for slow flow or the no flow or even thrombus dislodgement. Regularly tirofiban. We keep the ECT above 300 and intracoronary adenosine, nicorandil, and even adrenaline. Because this patient is lucky that he has a good LV function, but other patient most of the time they have borderline blood pressure. They are on inotropic support, and sudden dip in like sudden loss of the flow, they are in great dilemma.
Now we are using intercoronary adrenaline here. Is for the side branch flow or the main vessel?
No, sir. Overall, for the main vessel.
I mean, for the
Normally, for the side
flow,
branch, I don't use, sir. But considering this as a like a STEMI subset, and once there is a like loss of flow.
Yeah, for slow flow, no flow, I think it does help.
Yeah, for no reflow, it's a good drug, intracoronary adrenaline diluted. Yeah.
So what initially this, I mean, as sir has said that initial strategy in the mind looking at the ECG, there was always a dilemma. This vessel could have a big diagonal or something. And then this case was little difficult in the approach that because it's a STEMI, not every STEMI will come with a straight away lesion. And this was a bifurcation, which the vessel looks short, I mean, smaller caliber, but again, even the 2 vessels can be a difficult subset. And with all the regular, I mean, this is as compared to for a CTO, this is a regular case. But considering the overall, the presentation and the preparation for the case, at times it creates challenges. So most of the time in ACS, we have a quick in, quick out strategy. We want to keep it simple and we want to keep it safe. But certain anatomies, especially bifurcation lesions, and at times the incidence of a chronic occlusion, and in addition to it, an additional lesion. So all this is very not so common presentation in young patients at least. And at times, what sometimes we overlook certain aspects, but it creates more hurdles during the cases.
How about no mention about aspiration?
Yes, sir. Thrombus aspiration, if if they are presenting in the early time, I mean within the 24 hours or more earlier than that, definitely it helps. This patient already was having collaterals and here like day 4 of STEMI.
So the right injection was done from radial.
Sir, actually I did the case from radial, so I took a femoral approach for the right injection. Sorry.
I would feel when the diagnostic angio is opacifying LAD so beautifully uh, during right injection, I would probably make a very positive effort to have a simultaneous right injection because it can clearly delineate which way your wire should turn and which way you should progress forward.
Yes, sir. Actually, with the simultaneous injection only, I crossed the this, but those images were not shared, so I couldn't show them the exact crossing. But I mean, this was a very short segment, and we actually entered the main procedure were done through radial, and then somehow it was not able to cross the lesion. So then we started with the regular as considering as a CTO case, and then approached the same steps.
What is the post-procedure strategy? I mean, you continue tirofiban heparin as a combination and you maintain.
Normally, if whenever I encounter a slow flow situation, we I don't use LMWH, but if there is a high thrombus or there is a slow flow LV dysfunction, if the patient is hemodynamically unstable, I give LMWH for at least 2 or 3 days, just like a STEMI case. And tirofiban we give for 12 hours. Most of the patient land up with hematuria or something eventually. I mean, out of whatever patient treated.
Most or occasional patient gets him.
So once our flow is good, final flow, most of the time we don't have to give tirofiban because we all load the patient with ticagrelor. Before, when we were loading with clopidogrel, we are using lot of tirofiban. And after, I mean, it was after working with you on 1 or 2 cases, you had given me the confidence that I generally don't use so much tirofiban. So I applied that knowledge.
So how is the LV function now? It's about 2 months, right?
Yes, sir. The patient LV function has improved. It is normal LV function now. There was only hypokinesia to begin. So his rest of the segments were all hyperkinetic. So the LV function is now normal. Patient is also doing good. Today only I just called up the patient just to inquire how is his health going. He had come for normally they come for a follow-up at third month. I mean at day 15 and the third month. So we most of our cases are done through the government scheme which is available in our hospital. So
why are you mentioning that the most of the cases are done
no, sir. I mean, this
through
patient,
government scheme?
lot of non-affording patients, and also the patient subset become difficult when they come in ACS scenario, and there are financial restrictions to use more hardware in many of the cases when they are not having good insurance claims or good financial capacity. Like thrombus aspiration and those things, if they're not available, they become difficult to use.
Dr. Rajiv, any comments?
Yeah, Dr. Hiramat's world of wisdom, the contralateral injection has to be decided in the diagnostic angio itself, because that really, as Dr. Hiramat told, how easy it was approaching the segment. So contralateral injection, if we have, it helps anyway.
Especially when you are seeing it so beautifully all the way to the site of total occlusion. I think your wire, movement, direction, everything becomes very easy.
Yeah.
You probably would have saved time and thus probably saved muscle, heart muscle also.
Definitely.
Can I make a couple of comments, if I'm permitted? Yeah.
Yeah, go ahead, please.
A very nice case and very beautifully done, especially when you have a complex kind of a trifurcation with a septal and a diagonal. The strategy has to be slightly different. I will just make a couple of technical comments. When you see something like that, that LAD is totally occluded and diagonal is the flowing vessel. LAD territory may be infarcted and diagonal territory may be the viable territory, which is giving hemodynamic support to the patient. So I would pay particular attention upfront to protect the diagonal artery with a wire, and maybe use a dual lumen catheter, which makes your crossing into the, put the catheter over the wire, and then with a dual lumen approach, it makes it easier to enter the main lumen of the LAD. And if you don't have a dual lumen catheter, put a small balloon in the diagonal and maybe inflate it for a short while and try to enter the LAD. That's another strategy which would work.
All this is before putting a stent in LAD?
Yeah. Before. This is upfront. And sometimes when you have a total occlusion which refuses to entertain a wire, you make a gentle dilatation in the side branch without a wire in the main branch. That modifies the plaques to a certain extent and helps you to cross into the true lumen in the main vessel. So these are some of the strategies, and upfront administration of eptifibatide and the pharmacology has to be very careful, especially in the ACS situation where you anticipate side branch occlusion. That anticipation is what gives you an advantage of a few minutes of time. And of course, you have done it well, and the final result is excellent. There is one small area of under expansion of the stent distal to your diagonal branch, which I would have expanded with a 3 or a 3.25. These chronically occluded vessels, they appear undersized because they are underfilled. And we tend to kind of see the distal vessel and undersize significantly, especially in the ACS situation. You should be careful with your stent sizing so that patient has a long-term good outcome. I would definitely post-dilate the stent after the diagonal branch. If you see the angio, you see an area of a short segment of under expansion of the stent. So these are my comments here. Very nicely done. ACS is a very difficult situation. Sometimes it's middle of the night. You don't have all the hardware in place, all the technicians and support, and you rarely encounter chronic total occlusions in an ACS situation with a STEMI, which is an extremely tight corner for you to get out of, but you have done very well.
Thank you, sir.
Dr. Pranav, what kind of coronary dilators you used in the coronary?
We normally we use our semi-compliant and NC balloons, and if there are fibrotic or calcified lesions, we use the cutting balloons.
No, I think he's asking about the pharmacology.
Yes.
I didn't get the question, sir.
Yeah, so the prevention of no reflow and slow flow is extremely important, because once it happens, it's usually resistant because the distal circulation is the one which is affected. So you have to preempt it with administration of vasodilators upfront. And the commonly used agents are nicorandil, which is extremely safe, and hemodynamically it's very neutral. You can inject as much as you want without a single millimeter change in systolic blood pressure. That's what we use routinely. We give boluses of eptifibatide, which I have personally found useful, though the clinical trials may not support that. Any patient who has an acute coronary syndrome by history, not by appearance of the lesion, because we do not see the thrombus many times. If the history is acute, I give a single bolus of eptifibatide. If I see a thrombus, I give a double bolus of eptifibatide, followed by nicorandil upfront. That is, as soon as you put the wire, even when you are not seeing the flow, you give it upfront, because the drug has to reach the distal circulation. So on the left system, it can go through the circumflex and reach the microcirculation, and thereby you prevent the no reflow phenomenon. Rather than doing things, once things go haywire, there is no reflow, pressures are falling, patient becomes symptomatic, then you try to inject everything, and then it becomes extremely difficult. And one agent I found it extremely useful is sodium nitroprusside. We put a microcatheter distally or something to inject distally beyond the site of occlusion where you see no reflow. Take the catheter as much as possible distally, slowly inject very dilute nitroprusside mixed with adrenaline. That gives you an excellent result. And many cases we have resolved with this particular combination, because nitroprusside alone causes significant hypotension, even in very, very tiny quantities when you inject it, very significant fall in blood pressures to systolic of 40 or 50. But you make a small mixture of epinephrine and sodium nitroprusside, it gives you excellent results. Try it next time if you have a really resistant no reflow phenomenon.
Sir, normally we are using nicorandil, adenosine, and adrenaline, and tyrosine also to as a slow flow agent. And most of the time I use the thrombuster to give to the distal bed. I've given a chance, I'll present. I have a case of refractory no flow, slow flow, and I use all the therapies to some like get the TB3 flow. So using a cut balloon, in that I use a cut balloon, thrombuster, and all the pharmacotherapies in multiple doses, because patients have myocardial bridge or they have a distal small vessel and with a diffusely diseased artery, and then at times when we take a shoot through the thrombuster or the microcatheter, we have a distal good flow, but because of the intermediate this disease or the lesions below the stented segments, they don't allow a good flow to be achieved.
Yeah. And all these strategies should be upfront rather than looking at things after no reflow occurs. Yeah.
Sir, one comment and question also. There was one study, a Chinese study, which showed that if you are using nicorandil at a dose, higher dose of 6 ml per hour, right from the patient landing, and if his BP is permitting, right from 2 to 6 ml. If at the higher the dose of nicorandil what we have used, the incidence and all the problems of this slow flow, no flow have really been very less.
I think yes, quite true, because compared to nitroglycerin, the hypotension is not a problem with nicorandil.
Absolutely.
So, if you're giving intracoronary nitrates, I think you would probably expect a lot of hypotension. And many cases during MI with a pressure of 190, I would probably feel that if pressure is borderline, balloon pump, we are very liberal on balloon pump usage. Because if you have established a forward flow with a stent, and if you have good blood pressure, I think it really, really helps.
Yes.
Thank you, sir.
All right. Dr. Keshwa, we are going to your presentation now.
Yeah, I'll just share my screen. Are you all seeing my screen? Just
Yes.
allow the
Yes.
slides are not moving. I'll make it slideshow now. Good evening, everyone, and it's a great honor and privilege to be with my teachers and my dear friends and colleagues to make this short presentation. I made this presentation at TCT 2023 in October last year, and I thought it would be interesting and a great learning experience to present this, as I mentioned it in the last session. So are the slides moving? Are you seeing the next slide?
Yes.
Yes,
So in nature, the bifurcations are quite intricate. If you observe the branching patterns of
No,
the trees
we
or on,
cannot see the next slide. Yeah, now we can see.
are you okay? Now you are seeing?
Yeah,
Yes.
now we can.
Okay. So the pattern of branching in nature is quite intricate. If you observe the trees around you or the branching pattern on the leaves, if you can see it kind of mimics the branching pattern in the coronaries. That's what that is my personal opinion. And when you try to treat this in a kind of a rigid way by putting rigid metal tubes into bifurcations and into small vessels, it is not going to produce the result that we are trying to achieve with good flows. So the idea that we can perfectly normalize narrowings at bifurcations of two elastic tubes by placing two rigid metal tubes is absurd, and an anatomical normalization, what we see angiographically, is always an illusion. I'll just try to illustrate this point in the next two slides. So you see that these are the stents implanted in coronary bifurcations. Stent distortion is a reality. We cannot discount that. When we try to access the side branches, we end up damaging the struts, we displace them. And what we think and do is not actually what is happening there. You see the kind of distortion with the various stents, even after kissing. It ranges anywhere from 8% to 28%. And how do we deal with this? How do we simplify things? How do we avoid distorting these metallic structures? So whatever technique we use, the culotte, the double kiss, double crush, we produce multiple layers of crushed stents. We do not know how exactly they will affect the flow dynamics in these vessels, especially at the bifurcations. These are some bench pictures showing significant disruption of the main branch stent as well as the side branch stent with loss of coverage at the side branch ostium. So these are all from the various bench tests that were shown in the bifurcation club meetings. So we'll now just go to patient examples and see how we can simplify the complex lesions or the complexities that we create in our mind. So I'll just tell you two short stories first of two patients. This is a 48-year-old gentleman who presented with diabetes and acute coronary syndrome. He had diffuse triple vessel disease, diabetic, typical Indian diffuse vessels, a very high syntax score. So he was referred for a bypass graft. He was declined for ungraftable LAD, which is a common situation. Whenever the surgeon sees that LAD is not a kind of a graftable vessel, they say, why open the chest for grafting a PD or an OM branch? So he is left on medical management. But if the patient is symptomatic and we do consider stenting, these patients commonly require too many long stents and too much metal into the coronaries, which we are kind of reluctant to get into that situation because we know that the events are very high in these patients, 30 to 40% restenosis in small vessels, even with the modern generation stents. So DEB to LAD, the drug-eluting balloon strategy, this is what I thought of in this particular patient, and just open that segment which is critical and then follow up with the patient to see whether the distal vessel remodels. And then if it remodels and becomes of a reasonable size, say 2 or 2.5 millimeter, then the surgeon may consider a CVG. Fortunately for the patient, in this particular patient, what we did a simple balloon dilatation in the proximal LAD to open the vessel and fill it with some flow. Worked well, and is asymptomatic at 1 year follow-up. and on optimal medical management. And we had some imaging which showed some residual ischemia, but not significant enough for a CABG. So a very complex coronary artery bypass graft surgery with maybe 2 endarterectomies turned out to be a simple drug-eluting balloon case. I'm not saying this is a perfect example, and what happens to these patients at follow-up we have to see over a period of a few years. But this is just one case example how you can simplify things and get the patient out of an ACS situation. The second example, the day-to-day, what we see in reality, 60-year-old gentleman who was traveling from Norway. He developed an anterior myocardial infarction elsewhere. He's diabetic. He didn't realize the symptoms. He came to us about 48 hours later with shock and severe LV dysfunction. And on day 1 of admission, he developed a hemorrhagic CVA with hemiparesis, which started recovering immediately. But he had ongoing ischemia. He went into hemometabolic shock, multi-organ dysfunction. The LFTs and the renal functions were deranged, and he was on ventilator for heart failure, acute LVF. Coronary angiogram showed a proximal LAD occlusion, which is the mark in this case. And what are the options in this patient? We supported him with an intra-aortic balloon pump and supported his circulation with multiple inotropes and things like that. But what do we do next? Do we implant a stent? So we thought we'll just put a drug-eluting balloon alone, which there are a few studies supporting this kind of strategy in patients who are at high bleeding risk. When they have an hemorrhagic CVA, it's one of the most difficult situations. When you have an ACS, STEMI, and a hemorrhagic CVA, or some kind of a bleed which is happening, the GI and other nuisance bleeds can be tackled. We take that coronary thing takes the priority, and then we stent it and then give a dual antiplatelets and see what happens. But in this particular situation, where there is a very imminent risk of infarct expansion in the brain, which could lead to coning and future surgery, we chose the technique of drug-eluting balloon alone. And with a single antiplatelet regimen, we somehow salvaged this patient. We don't know whether that did anything to the patient, the coronary procedure, but the hemodynamic support, the intensive care support brought the patient out. And at 4-month follow-up, he's clinically stable, but he has some heart failure symptoms. He has ejection fraction of 20%. He is a candidate for a future LVAD or a transplant because he's 60-year-old and otherwise well preserved and affording, and that is the plan in the future. So these are just 2 patient stories where we can think differently out of the box. These are not standard recommended therapies. So if you want to go by the guidelines, the therapies may be different. But if you think that a simple solution can be given to these patients, please consider them. Now we'll go to
patient, are you going to angio him sometime now or no?
Yeah, we are going to angio him. His creatinine is still a little bit 2.3, 2.5. So we are just waiting for it to come down a little more. And he has had one subsequent admission with anemia and heart failure, which we corrected with iron infusions and heart failure treatment. So we are just waiting. We'll certainly, I would certainly personally want to see what has happened to that balloon result, and if his hemorrhagic CVA is resolved now. He is completely neurologically intact. So we could consider a possible stent if there is a residual lesion. Yeah, so now I'll go to the next few examples of where I'll show you the angios also of the cases. So these were the cases which were presented at the TCT. The first is a 74-year-old gentleman, had a culotte to left main LAD and left main circumflex in 2014. He is a post-renal transplant, bilateral amputee. He is a vasculopath. Coronary angiogram in February 2023 showed severe in-stent restenosis of mid-LAD stent and LCX stents, and a new stenosis in the mid circumflex. So he really is coming back. And after this procedure also, he has come back a couple of times. We have done everything possible in this patient, including IVL. We have imaged him. We have put, he has had multiple procedures. Every year, he is a loyal customer. He keeps coming back with acute coronary syndromes. So in this particular event, we did a drug-eluting balloon to LAD with a magic touch and circumflex with a 3x30 at the bifurcation. We stented the mid circumflex, which had a separate lesion, without involving the bifurcation with a Zine stent. So I'll just show you briefly the angiogram. This was how his lesions looked at the onset. Very calcified, The distal LAD is diffusely diseased. Patient and attendant several times asked whether he could go for a surgery, but no surgeons would kind of take him considering his status of post-renal transplant and all. So this is the pre and the post. I'm just showing for brevity, for case of brevity. So we have put an additional stent in the mid circumflex, and at the bifurcation, we have just done a kissing dilatation with 2 drug-eluting balloons. This lasted fair enough for about a year, after which he came back for another repeat procedure with a new stenosis in the mid LAD, which we again treated with a drug-eluting balloon, and after that he has been doing well. So this is one of the cases. This is the second patient, a 74-year-old gentleman, again a diabetic status post PCI to left main to LAD in 2012, and presented after 9 years, 2021, with ACS and a tropa elevation, PCI left main to circumflex, and a kissing balloon inflation was done with a proximal optimization. Again, it presented in July 2022 with an occluded circumflex at the ostium and a critical left main to LAD stenosis. He had multiple cardiac arrests this time in the emergency room with pacing, and IVP was taken up for the procedure. And this time, because of the critical condition and already existing couple of layers of stents in the left main and LAD, we just did a drug-eluting balloon strategy for this patient, and you can see the good result. This is the initial picture where you see a critical stenosis in left main to LAD, and following just a balloon dilatation. You can't believe it that without stents, this has appeared, because they are pre-existing stents, only a drug-eluting balloon. Of course, the patient was pre-dilated pharmacologically, he was treated, and we used a cutting balloon for the ostium of the LAD, and then the final inflation is a kissing with a drug-eluting balloon. So that is the result in this particular patient. So the next patient is a 73-year-old man, gentleman, diabetic, hypertensive, presented with unstable angina, and angiogram showed a critical circumflex and RCA disease in August 2022. But RCA had multiple aneurysmal segments. This is one situation where you cannot size your stent. How will you size in such a vessel? I'll just show you the vessel. The circumflex was, of course, stented with a single stent. If you see the right coronary artery, there are multiple stenosis. There is an aneurysmal segment, and however much you try to size the stent, you will end up with long stents right from the distal bifurcation up to the ostium. But in this case, we chose to just treat that critical segment with a drug-eluting balloon without touching the aneurysm at all. And we got the patient's symptoms relieved, and he's doing fairly well with no clinical symptoms and a negative treadmill at about 1 year. So this is another situation where there is a big size mismatch, and you are unable to decide whether to let the edge of the stent into the aneurysm hang there, and what kind of sizing you do and what kind of length of stents you implant becomes a question. You just use a drug-eluting balloon. This is patient number 4, a 76-year-old gentleman, again diabetic, hypertensive, post-CABG. He has multiple stents, at least some 6 to 7 coronary stents, multiple procedures, carotid stenting, femoral iliac stents. He is another vasculopath with multiple CVAs. He had a pacemaker. Then again presented with pulmonary edema and NSTEMI in October 2022. And angiogram showed a patent lima to lat and occluded ramus at the ostium. So again, we treated this particular patient with just a drug-eluting balloon to the ramus. That is the pre-procedure, and this is the post. A fair result, not a perfect stent-like result, but there is a good TIMI3 flow in the ramus, and patient got better. After this, patient remained asymptomatic for about a year, and about 6 months ago, he died of a massive GI bleed outside in another hospital. We couldn't get him for follow-up into our hospital. So that is the story of that gentleman. The next patient, I think this is the last patient, is a 67-year-old male, diabetic, hypertensive, normal LV function. He had an angioplasty left main to LAD crossover in 2019. And in October 2022, he presented with unstable angina and had an instant restenosis of left main to LAD stent. Just remember, this patient had that left main to LAD stent in another center with imaging and multiple kind of interventions. And LCX ostium was noticed to have some pinching at that time itself, but the operators decided that nothing needs to be done, but patient quickly became symptomatic. And you can see the very severe instant restenosis in the left main LAD stent, and also a severe stenosis at the circumflex ostium. This again, we could have done different strategies, put another stent into the circumflex or crushed or reverse culotte or whatever. But we just put a drug-eluting balloon, which seems to have done the trick for this patient. He is again asymptomatic at follow-up and doing well at, I think, about a year of follow-up now. So what are our thoughts when we see complex lesions and approach it with a drug-eluting balloon? It significantly simplifies the procedure because there is no additional strategy involved. And as we know that a simple strategy or a provisional strategy of crossover technique greatly simplifies the procedure, the procedural time and contrast use, everything becomes lesser. There is no metal on the side branch when you use a drug-eluting balloon. The vasoreactivity of the vessel remains preserved. This is especially important if you are treating a segment of LAD, say mid to distal LAD with a long stent. Instead of that, if you put a drug-eluting balloon and this patient subsequently requires a bypass graft surgery, you have a good vessel which is uh, preserved in function as well as in size for a graft. The segment is available for future bypass. Sometimes in untreatable diffuse disease, you can approach it with a drug-eluting balloon with sizes of vessels up to 2 or 2.25 millimeter, where you do not want to put a stent, you can treat with the drug-eluting balloon dilatation. Of course, there are some concerns about longevity, where more and more clinical trials are now going on with drug-eluting balloons alone without stenting. We don't get a stent-like result. So as coronary interventionists, we always like the vessels to look pristine, smooth, and have a stent-like result. But in drug-eluting balloon, you may not get that. You may see small dissections. But if the lumen is large, there is less than 30% residual stenosis. Especially the strategy we have adopted in the last few cases, especially in the LAD. We all know that LAD is a different vessel. It behaves differently. It's a sentient being of its own. So in LAD, what we do is we put a FFR wire as a primary wire and do the procedure on a FFR wire. And both pre and post procedure, we measure the FFR. And if we are happy with the FFR, the resting flow ratios, we leave it without a stent, mid and diffuse lesions. What do we do with the dissections? We also in the imaging studies with drug-eluting balloons that smaller dissections which are not occluding the flow, where TIMI-3 flow is preserved. The minimal luminal area seems to predict the long-term patency of the vessel. So if the minimal luminal area is good in any of the vessels, you can leave alone dissections. Residual stenosis, like I mentioned, less than 30%. The additional cost is a bit of a concern because at present, the drug-eluting balloons seem to cost more than a drug-eluting stent, which is an unfortunate paradox in our country. And of course, you will all ask for data, I know, which is lacking at present, but a large amount of data will soon come in the next 2 to 3 years in this particular field. So what is the future ideal solution for a coronary bifurcation? We are primarily concerned with the bifurcation, especially the left main. Is it a 3D printed bioabsorbable platform, which leaves the vessel untouched without a metal cage, which we can in the future intervene? Would it cause less event? These are all my thoughts. A hybrid strategy like metal for the main vessel or an absorbable material for the side branch or just a drug-eluting balloon. A dedicated customized bifurcation devices, which we have seen over a period of time, both the bare metal variety and the drug-eluting dedicated bifurcation stents, they do seem to kind of work well acutely, but long-term results are still awaited. Simplifying the complex strategy by always thinking of a provisional single stent strategy and drug-coated balloons for the side branches seems to be the answer at the present moment. So the take-home points I would say are drug-eluting balloon is a good choice where we want to avoid more metal layers, especially in restenotic vessels. In de novo vessels, when the disease is diffuse and you want to wait for the vessel to remodel, you can just put a drug-eluting balloon. Osteal lesions during a crossover stenting, DEB is a reasonable option. Significant size disparity, as I showed in that right coronary artery, drug-eluting balloon is again a good option. And in the future, if the longevity compares with that of a DES, I think drug-eluting balloons will become standard of care in many lesions. Thank you all for patiently listening to this presentation, and warm greetings from the city of palaces. This presentation in the TCG happened on the Dasra day when the palace was lit, so I put this photograph there too. Thank you all.
Sure, nice presentation. I think many would start using DEB, and I'm sure the percentage of DEB usage, which is very, very low, in fact, it is going down, will probably pick up with this kind of presentation. I would very strongly feel that whenever we are putting stents where the surgeon is likely to put a graft in future if there is a problem, I think these are definitely the sites like mid and distal LAD is definitely a site for DEB, which you mentioned in your second last slide, pros and cons. So I would feel wherever you are going to put a stent where surgeon is likely to put a graft, I think leave it for the surgeons the graft there. What about dissection? Do you rule out dissections before you put a DEB? And also, can you tell us about the technique, like the DEB to vessel diameter ratio 1:1?
Yeah, we should take a 1:1. And whatever preparation you want to do to the vessel, like you want to put a cutting balloon in the ostium, or you want to do a pre-dilatation with a non-compliant balloon, finish all that before. And in my personal opinion, the last kind of inflation should be with a drug-eluting balloon. We generally go at about 8 atmospheres and keep it for about 2 minutes if patient tolerates it well. But of course, in the left main bifurcation, you cannot hold it for 2 minutes. So you give an intermittent deflation at about 30 seconds if patient tolerates it well, deliver the drug, and then again give another inflation. Sequentially, you can do that. We have done several cases with a normal balloon in the left main to LAD and a drug-eluting balloon in the side branch used for the final kissing inflation. It makes the non-compliant balloon in the main vessel and a semi-compliant drug-eluting balloon in the side branch, but that is reasonable. Dissections, like I mentioned in the talk, if they are major dissections, major, I mean, there is a loss of flow, loss of TIMI flow slows down, or patient has some symptoms. You have observed with your interventions that whenever there is a vessel dissection, the first thing is patient becomes a little restless, makes a little movement, and he has chest pain. So if you observe that, take a shot. If TIMI flow is preserved, you can again do a small low pressure balloon inflation to seal that dissection, which many a time helps. In the earlier era, when there were no stents, we used to inflate the balloons very gently and also deflate the balloons very gently. What we currently do, I have seen many operators, is that you go fast up and fast down, which kind of puts a negative pressure on the wall of the vessel, especially in the presence of thrombus, in the presence of a vulnerable plaque. Go up very slowly and come down also very slowly. This kind of slow inflation and slow deflation technique has not only reduced the number of dissections, reduced the number of no reflows, reduced the number of vessel occlusions in acute STEMI cases, especially. We have done over 600 cases with this technique, and a very significant reduction in no reflow phenomenon with this slow inflation and deflation technique. Many of us inflate slowly, but when we deflate, when the cardiologist says deflate, the technician immediately pulls out, it makes it quickly negative, which we avoid. So we ourselves hold the indiflator and slowly come down with like 2 atmospheres every 5 seconds and hold it for some time. So this has certainly helped. So this is the technique which we follow here.
The vessel wall, vessel diameter and the balloon diameter should be 1:1.
1:1, yeah.
And we should be using the drug balloon only to deliver the drug. It's not
Not for treatment.
it's not something where you want to get a stent-like results, and that's what you're. So prepare everything like a stent-like result, and then a drug. I think that is the best way in which you can.
That is a key, sir. That is a
yes.
key. Yeah, the other thing we observed is we have been using drug-eluting balloons for about 8-9 years now, 2015-16, when they first became available. The drug-eluting balloon technology also has significantly changed. And recently there was a demonstration in the TCT about a nanoparticle coated drug balloon, where you can control the amount of drug from outside and have a kind of a metered dose delivery of the drug. The time as well as the drug delivered at the coronary is measured, because the question was, when you put a drug-eluting balloon, you really don't know how much of drug is delivered where, and whether it is approximated to the vessel wall and all that. But this kind of new balloon technology will come in the next 1 or 2 years with the USFDA approval. I think the research into drug-eluting balloon has got a big shot, and we'll soon see the new generation of drug-eluting balloons. Like we saw the drug-eluting stents moved several generations with thinner struts and all that. With this nanotechnology, we'll certainly have newer technologies of drug delivery to ensure that what we plan to give at the particular site, the right kind of dosages, right kind of drug delivery will be done. Yeah.
Why do you think drug balloon has not become all that popular? I mean, there are certain centers, some certain regions in the world which are all going for drug balloons, but it's not a universal thing. Yes.
Yeah, it kind of had a phasic variation. Initially, there was a lot of enthusiasm, and as interventional cardiologists trained to implant stents, there was an initial resistance to drug-eluting balloon technology. And I was also of the opinion that the large vessels like 3 millimeter or more should always be stented. If there is a dissection, you should always put stent and all that. These are ideas fixed in our mind. So the resistance to new technology is one of the reasons, I think, where it is not being taken up at such a pace. But like I mentioned just now, if the technologies change, if the cardiologists are made aware that it is a really a useful technology, we have more data about longevity and follow-ups, it will certainly change our practice. After the use in the past 2 to 3 years, all our non-left main bifurcations, we are not using two stents at all. It's a single stent strategy in 100% of the cases. I've stopped putting stents at bifurcations which are non-left main. But the left main is a different matter. As we all know, the left main bifurcation is totally different. De novo left main complex bifurcations, where the lesion extent is more into the circumflex, we always use a two stent strategy still. So we should put a lot of common sense into it and see where we can avoid metal and what kind of situations will potentially benefit the patient, the younger patients, if they require multiple procedures in the future. Consider this as an alternative.
I would strongly feel that whenever you're putting a stent in a location where the surgeon is likely to put a graft, say 10 years down the line after your angioplasty, I think we should avoid that area and keep it for drug balloon. So you can put a long stent in, say, mid and proximal LAD, proximal RCA, but PD should get a DEB and not a stent.
Yeah. The other point you should keep in mind is whenever you speak to surgeons when they are treating patients who have stent occlusions, they say that the quality of the vessel distal to a implanted drug-eluting stent is always like a scarred vessel. Not only the stented segment, but the vessel after that also has some effects, whether it is due to polymer or reaction to stent or inflammation or drug effect from the first implanted stent, you don't know. But surgeons always say that, oh, you have given me a stented vessel. It's so difficult to open and put and preserve distal flow and the graft patency. Yeah, so that should always be in your mind.
If we put a stent in proximal LAD, the surgeon has problems with grafting the mid and distal?
No, there is no problem in grafting, but they always comment that the quality of the vessel was poor. It is kind of fibrosed, it is thickened and things like that.
I think we should tell the surgeon, like we are doing a case who's had a bypass surgery, how difficult it is for us. So I think it's all in the game.
It is the same. We know how grafted vessels behave, and same way they comment about stents too. Yeah.
Okay,
Sir,
Dr.
sir, I had
Rishikesh,
a question.
I think we are probably coming to the end of today's discussion. Anybody has any comments? Dr. Rajiv, you want to comment on Dr. Keshava's talk or
Great
DEB for that
presentation.
matter?
This drug-eluting balloon is a friend for rescue. Prolonged inflation and deflation are mandatory, and as Dr. Hiremat again brought out that leave the battle open for the surgeons. Use a drug-eluting balloon if they need it.
Yeah, I think before we talk of drug balloon, have a perfect balloon result on the lesion. So no dissection, vessel opened fully, all these, and then only the drug balloon will work very, very well.
Sir, I have one question, sir. Like in bifurcation lesion, when we are doing the final casing, so there we are deflating simultaneously both the balloons. So when we are using depth, so both will go slow deflation or simultaneous fast deflation.
I would, depth should be only to deliver the drug. It should never be used as another balloon. So you do a perfect job, and then you take a DEB and deliver the drug.
And once you have completed the drug delivery, the final KBI we do with the drug-eluting balloon itself, but then we do the usual inflation and the deflation.
Yes. So the two times we can do in that case.
Yeah, because you cannot keep the balloon inflated in a left main bifurcation for 120 seconds.
Okay, Dr. Rishikesh, I think we are probably coming to the end of today's presentations
Yes, sir.
and discussion.
Yes,
Anybody
sir.
has any
Yes,
comments?
sir.
Are there any
And I'm
questions in
sure,
the box? Are there any questions?
yeah, let me check if there are any questions. No, I think there are no questions in the chat box.
No, sir, not.
But I'm sure audience must have enjoyed today's insightful discussions and interesting cases. So before we conclude, I would request our course director, Dr. Hiremat sir, to share your concluding remarks, and then I'll go for vote of thanks.
Yeah, I think this presentation, many times it's on Thursdays or Wednesdays, but it sort of brings life back. I think many of us are doing same and similar procedure day in and day out. But like today's Dr. Keshwa's presentation, I'm sure my percentage of DEB will go up. I'm not a big believer of DEB, but yes, I think learning from somebody who has more experience makes you wiser, and I'm sure I will sleep tonight thinking about drug balloons.
Thank you so much, sir.
Thank you, sir. So we are nearly at the finish line, but before we conclude, let's express our gratitude to all who made this scientific program possible. I extend my deepest gratitude to respected course director Dr. Hiremat sir for the guidance and expert comments. I would like to express my sincere gratitude to our distinguished moderators, Dr. C.B. Keshavamurthy sir and Dr. Raju Gupta sir for sharing their knowledge and expertise with us today. I would also like to thank Dr. C.B. Keshavamurthy sir and Dr. Pranav Shamraj sir for their insightful case presentations. Your contribution has undoubtedly expanded our understanding pertaining to the cases discussed today. I would also like to thank our esteemed audience for their time, continued love, and support for this no thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thanks to the Emcure team, and we are happy to be part of this academic experience. Thank you.
Emcure is from Pune,
Thank you.
Rishikesh.
Yeah.
Yeah.
Thanks.
Yes, sir.
Yes.
Okay.
Okay, good night, everybody.
Thank
I
you,
hope
sir.
we
Thank
all
you. Thank you all.
sleep with wiser thoughts tonight and probably put many of these good thoughts into practice from tomorrow. Thank you all.
Thank you, sir.
Thank you, sir. Thank you for your comments. Good night.